Hello students. Welcome to chapter 19, coronary heart disease and hypertension. This is a very important chapter. We are getting serious now in the course because we are going to talk about the heart and all the conditions that are caused by improper nutrition. Okay, so take notes. As usual, pay special attention to that's good to know. Also the NCLEX alert, because I've seen this material in NCLEX. And also NCLEX maximum alert is for sure. You're going to be tested on this. Okay, so now, cardiovascular disease is going to be named in this lecture as CVD from now on, okay? Is the leading cause of death in the United States. Right there, that's good to know. NCLEX alert. Please know all your statistics and your leading cause of death in the United States. It's very important for you to remember that. Every day, thousands of people have heart attacks and strokes, and millions of others continue to live with various forms of rheumatic and congestive heart failure. When we talk about rheumatoid arthritis, these patients are having problems with the heart, and they are not having they are having very severe problem with the heart, okay, if the condition is not treated well. Also, we are going to consider atherosclerosis and hypertension as a risk factors involved for coronary heart disease. In addition, we will explore ways to the nutrition and lifestyle modifications to reduce risk factors and help prevent the disease. So we are going to play a video. It's about the coronary heart disease for you to understand. Usually I select videos that are very short, okay? So let's see. Let's watch this video.
Coronary artery disease, or atherosclerosis, is caused by plaque buildup along the inner walls of the coronary arteries, the major blood vessels that supply the heart with blood, oxygen, and nutrients. Plaque consists of fatty materials in the blood that can decrease blood flow to the heart, often resulting in a heart attack. Risk factors include family history, high cholesterol, high blood pressure, and lifestyle choices like smoking, alcohol consumption, and lack of exercise. You can reduce your risk by pursuing a healthy lifestyle or by taking medications.
Thank you. Right there, this video in 40 seconds is telling you the risk factors, the causes, and how you can correct this condition immediately in 40 seconds, okay? So the coronary arteries are the major arteries and branches that serve the heart. We are not talking about the aorta or the venous artery that is entering the heart. No, we are talking about the coronary arteries. Are arteries that are on top of the heart, like in a crown distribution, and those are the ones that are providing oxygen to the heart. The arteries lie across the brow of the heart and resemble a crown, as I was telling you. Coronary heart disease is the term we use to describe disease affecting these vessels. So atherosclerosis is the major cause of coronary of CVD. So we saw in the video is the plaque of the cholesterol, basically, right? And the underlying pathologic process in coronary heart disease, characterized by the presence of fatty plaque on the inside lining of the major vessels. Atherosclerotic plaque is largely composed of cholesterol. Scientists believe that the plaque forms in response to an endothelial injury. When I say endothelial, means the inner layer of the vessel within the artery, and inflammation ensues. Atherosclerotic plaque may begin as early as childhood in susceptible individuals. So, in a previous video, I mentioned you that usually we create memory in the cells from 1 year to 7 years, okay? So it's very important that we create the good memory in the cells. Good memory means that we give proper nutrition to the children. If between 1 and 7 years we are going to create a habit of consuming high cholesterol, steaks, fried foods, nuggets, and butter, right? So we are already creating atherosclerosis. This is not going to happen from Monday to Tuesday in an adult patient. No, this condition is going to be created and is going to be starting in the childhood. Okay. So the disease is characterized by the presence of fatty plaque in the inside lining of the major vessels. Atherosclerosis plaque is largely composed of cholesterol. Now, the thickening of the artery or the development of a blood clot may eventually cut off blood flow. So not only we have the plaque, but there's a risk of blood clot. When deprived of their normal blood supply, cells die. Of course, if they are not receiving the nutrients through the blood, neither the oxygen. And this is called infarct, a myocardial infarction or heart attack. So when I say MI or heart attack, is the same. Okay? Myocardial, myo refers to muscle. So myocardial is the muscle of the heart. And this results if the affected blood vessel is a major artery that supplies vital nutrients and oxygen to the heart muscle, the myocardium. Angina pectoris or chest pain, radiating down the left arm is a common symptom of a MI. Okay, in men, this is very common. In women, she can feel like stomach pain or gastritis, okay? And they will go to the hospital thinking that they are having, a severe episode of gastritis or ulcers, when in fact they are having an MI. If the affected vessel is a major artery that supplies the brain, then the blockage causes a cerebrovascular accident or a stroke. So we have two pathways then. If the artery is supplying to the heart, an MI can occur. If the artery is the one supplying, nutrients to the brain, and the atherosclerosis happens there, then the problem, the patient can have a stroke or cerebrovascular accident. Let's move forward. This is a nice diagram that is explaining through colors what are the age-adjusted death rates for selected causes of deaths for all ages, right? And you see that the ones that are having the most amount per year, right, are the ones in blue, which is cancer, we know that, and then is the heart disease, okay? So now this is a very beautiful diagram, also an atherosclerotic plaque in an artery. So you see the endothelium, you see the plaque, okay? And let's move forward. Relation to fat metabolism. So we will briefly cover 3 of the substances that are specifically relevant to CVD again here. Total cholesterol, okay. High blood cholesterol levels increase the risk for the deposition of cholesterol, fats, fibrous tissue, and macrophages. Macrophages are a type of white blood cells of the innate immune system that engulf and digest pathogens such as cancer, microbes, cellular debris, or foreign substances. So this presence of the cholesterol in the arteries is causing different types of events, right? Not only the cholesterol, but also the immune system, the macrophages are gonna come into place because remember, we are damaging the endothelial tissue. So that's why they are participating, okay, in this process of atherosclerosis. The CDC, okay, reports that 27.1 of American adults older than 20 years of age have high total blood cholesterol levels exceeding 240 mg/dl or are taking cholesterol lowering medications. Dr. Matalana, so what is the normal range then for total cholesterol? Normal levels of total cholesterol is less than 200. So the CDC is telling you that 27.1% of American adults older than 20 years, so we are talking about young adults, they are already having some kind of cholesterolemia, right? Or they are taking cholesterol lowering medications. Many individuals with hypercholesterolemia also suffer from obesity and hypertension. And it's always like that, always like that. You see a patient entering the hospital, or in my case, in my practice, and immediately I see distended abdomen. I know myself. I know the patient is going to have either hypertension, hypercholesterolemia, or diabetes. Distended abdomen is telling you that. So when you go and see the history of medications the patient is taking, there you go. You see the statins that are the medication for cholesterol, or the different types of hypertension medications. Now, lipoproteins. Lipoproteins, okay? Fat is not soluble in water. We know that, right? Therefore, it is carried in the bloodstream in small packages, that means in the vessels, in small packages wrapped with protein called lipoproteins. So you have a little molecule of fat, right? And is being carried through lipoproteins. We produce lipoproteins endogenously in the intestinal mucosal cells after consuming a meal that contains fat in the liver, that contains fat and in the liver as part of the ongoing process of fat metabolism. So these lipoproteins are going to be created in the intestinal mucosal, okay, after consuming a meal. And also the liver is going to participate in this. Lipoproteins carry fat and cholesterol to tissues for cell metabolism and then back to the liver for processing as needed. Dr. Matalana, I thought fat and cholesterol were the same thing. No, they are not. So the difference is that they are both lipids, right? But they are found in the food you eat and they circulate in your bloodstream. Cholesterol has a more complex chemical structure, is more complex compared to fats. In the body, cholesterol is bound to protein as low density proteins, which is your LDL, or your high density, your HDL, okay? Breathe, relax. We are going to explain this on detail little by little, okay? Now, the percentage, okay, I think I have to, okay. Lipoproteins carry fat and cholesterol to tissues for cell metabolism, okay, and then back to the liver for processing as needed. So that right there, that's good to know. NCLEX alert is part of your pathophysiology. Lipoproteins carry fat and cholesterol to tissues for cell metabolism, okay, and then back to the liver for processing as needed. The percentage of protein, fat, and cholesterol content within a lipoprotein determines the density, of course. And we then categorize lipoproteins according to that density. Because proteins is denser than fat and cholesterol, those lipoproteins with the highest protein content have the highest density and vice versa. So let's go and analyze, okay, one by one. You have your kilomicrons composed of dietary triglycerides after digestion and absorption from the gastrointestinal tract. And these are lipoprotein particles that transport absorbed dietary, which is coming from exogenous, means that is what you are eating, exogenous fat to plasma and tissues, primarily the liver. Now we have the very low density protein, your VLDL. The liver forms this VLDL from fat. VLDL carries a relatively large load of triglycerides to cells throughout the body, and they contain approximately 12% of cholesterol. So these VLDL, in other words, are having a large amount of triglycerides, which is not good to have in high percentage in your blood work. And they also contain cholesterol. They have a very low density of protein. So very, very, very low presence of protein. Now let's move to, I want to say something about triglycerides because people, they really, you get confused between triglycerides, cholesterol, fat, okay? For example, triglycerol and cholesterol are both fatty substances. There are lipids, right? Triglycerides are fats. Cholesterol is not fat, as I explained before. The difference between cholesterol and fat, cholesterol is a complex compound, and fat is, different, is whatever you are eating. Cholesterol is a waxy substance your liver makes. Okay, your body uses it to build cell walls and help your nervous system. That's why cholesterol in appropriate amounts are going to help you to have good brain function. It also plays an important role in digestion and hormone production. Okay, let's continue. So now we have your LDL, which is your low density lipoprotein. LDL cholesterol carries, in addition to other lipids, at least 2/3 of the total plasma cholesterol to body tissues. Because LDL deliver cholesterol to the tissue, we consider them bad cholesterol. LDL is your bad cholesterol. And basically, if you remember that, you're safe, okay? We are not going to test you like we are usually tested when we have to take our certifications for nurse practitioners or PA or DMP, whatever, okay? And as long as you know that LDL is bad cholesterol, you're in good shape. With regards to cardiovascular health, LDL cholesterol is the major protein, lipoprotein of concern and the predominant focus of drug therapy. Yes, that's the one when the doctor prescribes a statin, that's the one they are planning to attack. Sometimes we group all the non-high density lipoproteins fractions like VLDL and LDL together as a marker of CVD risk. In other words, whenever we read the blood work, if we see the VLDL and LDL is high, now we are worried about CVD, okay? LDL have a low density of protein. Now, in functional medicine, we usually order, besides the VLDL and LDL, we order apolipoprotein B, which is the primary protein found in LDL and VLDL cholesterol. So this protein is also an independent marker for atherogenic risk. Okay, so now we have a patient, the patient VLDL and LDL is high. Patient is coming to my office for functional medicine. These tests are not covered by the insurance. You need to pay extra. I'm gonna order apolipoprotein B to see if the patient has effective, risk for atherosclerotic. Okay, and usually they don't do this because some people probably they have high LDLs, but they don't have the apolipoprotein B high. There's no presence of that. Okay, now high density lipoproteins. HDL cholesterol carries less total fat and has substantially high proteins, high density of protein than the lipoproteins, that other lipoproteins. Okay, so this is the good cholesterol, and the higher serum levels are a marker for reduced CVD risk. Now, When we read the cholesterol, we see cholesterol, we see VLDL, we see LDL, and HDL, the happy cholesterol, okay? Which is in the book, they are telling you, they call the good cholesterol. So whenever you see this, and if you see the HDL in good proportions, HDL means that somehow there is a protection against cardiovascular disease, okay? So individual with a normal waist to hip ratio, with a non-obese BMI, and who participates in regular exercise have high HDL levels relative to their counterparts. Again, a patient that is having a high HDL, for sure, it has a normal waist to hip ratio. They have non-obese BMI, body mass index, and they participate in regular exercises. How are we measuring, okay, the waist to hip ratio? So we are measuring that by, we have a video here. So I'm going to play the video. Very short video for you to understand how we do this.
Okay, I'm going to teach you how to do the waist hip ratio. You're going to need a tape measure. Okay, it doesn't matter if you use inches or centimeters, as long as you're consistent on both. All right, so for the waist, I'm going to hold this up. You are going to take the smallest part of your waist. Mine's a little high. Mine's way above my belly button. For me, it's here. And then I'm doing it first thing in the morning when I'm not bloated, okay, my least bloated time. And I measure my waist. And for me, it's 29 inches or whatever, okay? Then you're gonna take the widest part of your hips, so wherever your butt sticks out the most, okay? And then you're gonna measure that. If you did centimeters before, you do centimeters again. If you did inches before, you do inches again. Okay, 38. And then you divide the top number by the bottom number, and that is your waist hip ratio.
Thank you so much. Thank you so much. So let's say you see a patient that is showing up with distended abdomen. The waist to hip ratio is going to be elevated right there. Now you go to the laboratory work and you see that the HDL is low. I'm going to show you later, I'm going to share with you the normal levels, what you are supposed to have. So now, right now, we have two pieces of evidence that this patient may develop a cardiovascular disease. Okay. Thank you so much for the video. Okay. BMIs, just a little refresh. Okay. So we have the patient underweight. The BMI is going to be 18.5 to 24. Okay. Less than 18.5, sorry. So the normal BMI is between 18.5 and 24.9. Okay, that's the normal. And you should be able to calculate your BMI. Now, if the patient is overweight, it's going to be above 25, close to 30. Above 25, close to 30. Patient that has obesity is going to be 30 to 34.9. That's obesity class 1. Class 2 is 35 to 39.9. And morbid obesity, what we call morbid obesity, is above 40. So you have to practice your sport, start eating healthy, right? And you can measure your waist to hip, you measure your BMI, and you participate in regular exercises, and your HDL is going to go up. Very good. So here we have the graphic. You see the kilomicrons. The triglyceride is basically huge when we talk about the lipoprotein. This is the lipoprotein. The triglyceride is huge. Now the VLDL, the triglyceride still is a large percentage. Now in terms of LDL, now we have less triglycerides. The protein is very small amount, phospholipids and cholesterol particles are present. In your HDL, look at the amount of the protein. It's huge versus the triglycerides, the cholesterol, and the other participants. So that's why we need to eat good protein, lean protein, and reduce the amount of these saturated fats, in other words, right? We do not consume VLDL, LDL, or HDL. Thus, eating less LDL cholesterol or eating more HDL does not address the dyslipidemia. What is dyslipidemia? This imbalance. Either would be high cholesterol or low cholesterol. That is going to be represented by these markers, the VLDL, LDL, okay? So dyslipidemia means there is an imbalance in the cholesterol markers. Triglycerides, simple fats, whether in the body or in the food, is commonly associated with low HDL cholesterol, meaning if you see a patient with high triglycerides, for sure the HDL is going to be low. Physicians do not use blood lipids level as the exclusive criteria for starting cholesterol lowering medication. There is an algorithm for determining drug therapy, and this takes into account many factors, including the age, the ethnicity, sex, family history, blood pressure measurements, comorbidities, especially if the patient is diabetic or the patient is having metabolic syndrome. That I already shared with you that knowledge. I'm going to repeat it now. Chronic disease, kidney disease, or polycystic ovary syndrome. So in order for the PCP to start treatment, he's going to consider all these factors, okay? Risk factors, the American College of Cardiology offers a 10-year atherosclerosis CVD risk estimator on their website. You can go to this website and download the application. It's called ASCVD Risk Estimator. And I have this in my cell phone. Also, I have the CDC vaccination schedule. There's another application. There are multiple applications that you should get in your cell phone, okay, to help your patients. So if you are a nurse working in the hospital, you have a patient in the cardiac unit or telemetry, and then you see immediately right now the HDL, the triglycerides, and you put all that information in the application, and then they are going to ask you if the patient smokes. You have all that information in the file, in the chart of the patient. Immediately you can figure out if the patient is having risk for CVD. Okay, so we are going to talk about these risk factors: the age, the family history, the heredity, certain groups, especially the African Americans, Hispanic, Latino Americans. And this is good to know. You need to be familiarized every condition with the ethnicity, okay? What population is in risk for developing specific conditions, right? Native Americans and South Asian Americans have a high incidence of CVD than other races. Also, genetic abnormalities that result in abnormal high serum lipid levels include familial hypercholesterolemia and familial hypertriglyceridemia. So if your mom had a hypercholesterolemia, based on the genetics, for sure, maybe you are going to develop that. Let's be clear on something, okay? We can have, as I told you, the genetic factor, but if you provide the cell the good environment, these conditions are not going to develop. That does not mean this literature that is telling you that for sure if your father got diabetes, for sure you're going to get it. It's not true. If you provide the cell with a good environment, you're going to skip that condition, okay? But we have to consider the genetics, okay? So now, diagnostic criteria for metabolic syndrome, that NCLEX Maximum Alert. I've seen at least in my exam 4 questions about metabolic syndrome. Okay, 4 questions. You need to master this, and you need to know exactly the 5 criteria for the metabolic syndrome. Criteria number 1, increase waist circumference, means distended abdomen. There are specific numbers there that you need to remember. Criteria number 2, elevated level of triglycerides. Okay, this is the bad cholesterol. So it's going to be above 175. Okay, and criteria number 3, reduce HDL. So you have poor HDL in your blood. Hypertension above 130 for the systolic and higher than 85 on the diastolic. And then you have elevated fasting glucose levels. So your patient is having above 100 in the glucose. Okay, so there is a table here that I'm gonna share with you. I didn't find this in the book. Okay, so is important. That's why this video, I do these videos, because I have time to explain on detail everything. I cannot explain all these facts in a 60-minute class. Okay, it's impossible. So let me open this. Okay, so this is the chart that is going to be helpful if for you want to take a picture, a screenshot while you are listening to the lecture, whatever. So you see you have your total cholesterol, your LDL, your HDL, triglycerides, and at the bottom you see the triglycerides to HDL ratio. Okay, so if you have a triglyceride level of 250, let's say, when the normal is less than 150, you see there is a green column, intermediate, and high. So this is basically the numbers you need to remember. Total cholesterol must be less than 200, LDL less than 130. HDL protection against CVD is more than 60. Okay, it's more than 60, and that's good to know. And triglycerides, normal, it should be less than 150, and non-HDL cholesterol less than 130. So now you have a patient with triglycerides above, let's say 250. And now the HDL, okay, is going to be 40. You are going to divide 250 and 40, right? You are getting a number. If that number is below 3, you see the triglyceride HDL ratio. If it's below 3, the patient is safe and is not having risk for cardiovascular disease. But if the number is between 3.1 and 3.8, there is an intermediate risk. But if it's above 3.8, that's another marker. So you see right there, you have different markers. You have the HDL, you have the waist to hip ratio, you have these triglycerides to HDL ratio, right? You have all these markers. You have your metabolic syndrome marker, different ways that and also you have the application, right? That does everything for you. So you have different ways to identify if the patient is having risk for CVD. Okay, so let's continue. Now we also have the risk for blood cholesterol profile. We have total LDL. You know, the book is mentioning this, but they didn't give you a table with the numbers. That's why I shared a table. Poor diet quality, of course, another risk factor. Physical inactivity. Okay, sedentary behavior is a major risk factor that cause mortality and CVD in particular. Less than 20% of adults in the United States meet the national recommendation for physical activity. Less than 22%. So let's say in United States we are 400 million. 20% would be 80 million. So it's less than 80 million of people practicing physical activity, right? And they are sedentary. Is a lot of people. Okay, so let's continue. Risk factors. And also I want to mention that you have to remember the poor diet quality. That's good to know, okay? It's very important. And let me see. Okay, so now we are going to go to the risk factors for cardiovascular disease and future atherosclerotic events. So you have the major risk factors, dyslipidemia, we talk about the imbalance, low levels of HDL cholesterol, less than 40 for men and less than 50 for women is very bad. So 60 is cardioprotective. That's good to know. 60 is cardioprotective, okay? Now, also we have presence of a specific comorbidities such as hypertension, diabetes. So maybe the patient is having 45 and also has a comorbidity. Maybe it's having an inflammatory process like rheumatoid arthritis, psoriasis, HIV, okay? Also family history, we talk about that. And also high risk if the patient has a specific race of ethnicity, advanced age, is cigarette smoking, okay? Additional risk factors if the patient is eating, has poor dietary habits and high intake of animal protein, sugar, sweetened beverage, saturated fats, and is eating whole grains, unsaturated fats. That would be the goal, right? To eat whole grains, unsaturated fats, nuts and seeds. Okay, so I have a list of good sources of good cholesterol. Nuts and seeds, they are rich in protein, healthy fats, fiber, vitamin B and E, minerals such as calcium, magnesium. So you need to start creating this habit of eating seeds, right? Your pumpkin seeds, your flax seeds, your sunflower seeds, your nuts, your cashews, all those are having good benefits, right? And then the difference when we are talking about unsaturated fats, and also we need to specify the difference about monosaturated fats and polyunsaturated, right? Monounsaturated are better than poly and can be found in avocados. You can use avocado to make a spread on your bread instead of using butter, which is saturated trans fat. You can also eat more nuts, seeds, olive. Also, you can create like a tapenade. Tapenade is a olive that is chopped, or sometimes you put it on the food processor and you create like a spread for your bread. Okay, so there you go. You have avocado spread, your tapenade with olives. You can put onions, you can put garlic in that, or even peppers, right, on that tapenade instead of getting butter. Okay, or you can just put some olive oil in your bread. That's it. There's people that they are eating the bread, the toasted bread with olive oil, extra virgin olive oil, and it's delicious, right? Polyunsaturated can be found in sunflower, corn, soybean. Keep an extra eye in these two, corn and soybean, and make sure they are organic and they are not genetically modified, as I explained in the previous chapter. And flaxseed oil, fish, walnuts, and flax seeds. Okay, so the patients that are having elevated apolipoprotein, as I mentioned before, they are having risk factors, elevated inflammatory markers such high sensitive, your C-reactive protein, okay, ankle brachial index. So this is another marker. You see, there is too many ways to know, to figure out if the patient is having a risk for developing CVD. Let's watch this video. It's like 2 seconds video.
What is ankle brachial index test? The ankle brachial index, or ABI, is a simple test that compares the blood pressure in your arms and ankles. Why does this matter? A low ABI can mean you have peripheral artery disease, or PAD. PAD happens when plaque builds up in your leg arteries, causing pain and numbness. During the test, you lie on your back. A technician measures blood pressure in both your arms and ankles using an inflatable cuff. The results help doctors see if your legs are getting enough blood. Why might you need an ABI test? If you smoke, have diabetes, or are over 70, you're at higher risk for PAD. Symptoms like leg pain with activity can also be a sign. The good news? An ABI test can diagnose PAD early and help prevent complications. Your doctor might even use it to check your heart attack or stroke risk. So, next time your doctor suggests an ABI test, remember, it's quick, simple, and could be a lifesaver. Follow Medical Sales Mastery channel and watch our exciting
Thank you so much. So there you go. You have your waist to hip ratio. You have the application. You have this ankle brachial index. You also have your HDL markers for metabolic syndrome. There are too many ways to really follow up on the risk of a patient if they are candidates, right, for CVD. Okay, let's continue. Smoking, and exposure to secondhand smoke are major risks for atherosclerotic plaque formation and CVD. Smoking causes vasoconstriction. So, do you remember I explained to you the two properties of the vessels? They are flexible, they are elastic, and they are permeable. So if you are a smoker, you're going to cause vasoconstriction. The vessels are going to become very rigid. Compounding conditions, comorbidities associated with obesity, such as type 2 diabetes, hypertension, even premenopause, because the imbalance in the body on top of on a patient that is already having diabetes or hypertension, this patient is going to be suffering a lot. Okay. Recommendations to reduce the risk. So the most important way to prevent atherosclerosis, vascular disease, heart failure, and atrial fibrillation, okay, that is type of heart rate that is abnormally normal. So it's everywhere. AFib is to promote a healthy lifestyle, through life, and that's good to know. NCLEX alert. Poor diet quality is one of the most important risk factors for death and disability from CVD. Poor diet. You are putting the food in your mouth, so you are causing the condition. So poor diet quality is one of the most important risk factors for death and disability from CVD in the United States, and poor diet quality seems to be more the rule than the exception in all age groups. So let me tell you something right now. I'm going to share something with you. Patients, when they are having Medicare, Medicaid, right, and everything is covered for them, okay, all the tests, all the doctor visits, the medications, and everything, okay, they don't make any effort to change their lifestyles. Believe me, they don't care. I've seen patients in functional medicine that they are paying a lot of money per consult, per visit, and per treatment. So when you have to put money from your pocket, that's when the patient is getting serious. This is something that I know how healthcare is going to really find a solution, because there's no motivation, right? So I ask my patients first when they come to the clinic, doctor, I need help with this, and that. And I ask them straight, are you really serious? Are you gonna be able to remove all the causes, all the things, the dietary, the nutrition that causes your condition? Are you willing to remove that? Because they believe that I'm going to prescribe supplements or medications. It's not. Are you willing to remove really the causes of this condition? If they are really prepared, they're going to tell you that, yes, this is a change in the lifestyle. So that's something that when you ask somebody in primary care, under Medicare, Medicaid, are you willing to remove your sugar, your this? They are going to start making faces. It's like, oh no, what I'm going to eat then? So they are not prepared, because everything is given to them for free. That's something you need to consider. There is good, excellent patients that they take control on their health. Yes, but you have to evaluate if the patient is ready for the change. Bottom line. Okay? So see for further focus box modifiable risk factors for heart disease. And then you have, here is the box, modified risk factors for heart disease. The American Heart Association uses a 7-metric system for evaluating overall cardiovascular health, which includes smoking status, weight status, physical activity, diet, total blood cholesterol level, blood pressure, la 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 la. Okay, so these are the factors. This is a very nice graphic. Also, you can see people between 20 and 49 are having poor, this is the prevalence and an adjusted estimate for poor, intermediate, and ideal cardiovascular health for each of the 7 metrics, right? So it's very poor in the population between 20 and 49, okay, and the best one is between and the 20 and 49, the factor is healthy diet score, right? But the good one, look at this, between 20 and 49 they have the green, which is ideal, okay, and they are talking about smoking. So there is a good group of people that are avoiding smoking right now with the new regulation and the prices of the cigarettes. This is somehow helping the healthcare system. Dietary recommendations: the Diet for Americans 2025 and the American Heart Associations recommend dietary restriction on certain types of fat and cholesterol to reduce the risk of heart disease. More important is the consideration of the whole diet. Whole diet, so it's diet that you prepare at home with really fresh and homemade products, right? Instead of buying products in can or that are packaged, right? So those are not a whole, that is not a whole diet. So now we have the American Heart Association diet and lifestyle recommendation for cardiovascular disease prevention. Of course, it's going to be weight and physical activity. This is important, okay? This is NCLEX also, NCLEX alert. I forgot to put this. They are going to test you on this. NCLEX alert. So aim for at least 150 minutes of moderate physical activity. So please sweat a little bit. Or 75 minutes of vigorous physical activity, or an equal of combination of both weekly. Okay, so there is people that, no, I'm doing my walking, but they don't sweat. The hair remains the same. Okay, you have to do moderate or vigorous physical activity. And to lose weight, you need to increase the duration of intensity or physical activity to burn more calories than eating every day. So foods to focus: fresh vegetables, fruits, fiber rich in whole grains, nuts, legumes, and fat-free or low dietary products. When I say legumes, I'm talking about lentils, beans, okay, your kidney beans. Those are really good. Your chickpeas, okay. And if you have any intolerance or you have any problems metabolizing these products, then you remove them from the diet, okay? Because we don't want you to have any gastrointestinal issues, especially bloating, right? Also, you have to choose lean meats and prepare without added saturated fats or trans fats. So you're going to have chicken fried in butter or margarine. That's no. You can bake the chicken and use extra virgin olive oil, right? Use monounsaturated and polyunsaturated fats instead of tropical oils. To the garbage. Throw to the garbage your canola, your vegetable oil, your corn oil. Garbage. It has to be extra virgin olive oil, period. Or any form of saturated fat. So saturated fats and trans fats are found in butter, ghee. Okay. No, because ghee is the authentic butter, does not have any chemicals, but is saturated fat, trans fat. Okay, it's delicious. Yes, I tried, but the cholesterol goes to the roof. Coconut oil is not for cooking. Okay, it's good to do your oil pulling, probably use it for other conditions. You can use it in the skin, you can use it to prepare deodorants, but for cooking it's not. And especially if you are planning to cook in olive oil, in coconut oil, it's not. Palm oil, no. Cakes, biscuits, fatty cuts of meat, sausages, bacon, salami, chorizo, pancetta, cheese, croissants, cream, sour cream, blah, blah, blah. You name it, okay? Now, foods to limit or consume in moderation. You have 3, 4, 5 items here. I would say most important to limit the sodium intake, and that's good to know. Okay, for those with elevated blood pressure, limit the max to a maximum of 2300 mgd per day, with a good reduction, with a goal reduction to 1500. So start cutting the sodium little by little, okay? Limit red meat, processed meat, and refined carbohydrates. And in general, our recommendation is drink alcohol in moderation. 1 drink per day for women and 2 drinks per day for men. In my practice, honestly, this is not working. It's not really healthy to drink alcohol every day, especially when the recommendation is not really clear on what type of alcohol. Some people think that wine, you can drink wine every day, or this other things that you can drink vodka every day, and beer is the other one that I hear the most, right? No, I get my beer is very healthy every day. So I would recommend to stay away from alcohol, period. Follow the American Heart Association recommendations when eating out and uphold appropriate portion size. Do not smoke tobacco and avoid exposure to tobacco smoke. I've been walking lately in a specific park that is very popular for barbecues, and I can see, people is eating red meat, preparing charcoal, and on the side there is a lot of participants smoking, and children are playing around. It's really sad to see this. The children are exposed to this meat cooking charcoal plus the secondhand smoking, and we are creating memory cells for these kids. It's very sad. Lifestyle recommendations: regular physical activity, minimize sedentary behavior, tobacco, we spoke about that. And also, healthcare providers should encourage weight loss for overweight or obese individuals and refer their patients to a registered dietitian and nutritionist, which happens rarely. The doctor is going to tell you eat less cholesterol and less sodium, period, and you have to insist for a nutritionist. And some insurance, they don't pay for nutritionists, so I would strongly recommend you take the advantage of this course, read the entire book, look for information in YouTube channels. If you can become a health coach or have a certification in nutritional, would be excellent. It's a plus for you, your family, and your patients. Reduce a successful team-based care approach is important. That means the doctor, the nutritionist, the cardiology if the patient is having problems. Healthcare plans must consider a person access to adequate housing, transportation, financial means. That's why nutritionists are so important, because you may think that to have a nice and good nutrition is expensive, and it is not if you have the right knowledge. And probably the nutritionist can give you a hint and prepare a plan for you at the beginning, and then you just follow that. Okay. Okay, let's continue with this. Here is a client with a history of cardiac disease that is undergoing evaluation for exercise tolerance with a treadmill stress test. And this is important because there are patients that are having a history of CVD, and they start doing physical activity that they cannot tolerate, and instead of getting healthy, they put their health condition in jeopardy. So we need to evaluate the patient first. Now, translated broad terms of advice. When healthcare providers recommend that their clients follow a healthy eating pattern, such as that outline in box 19, the Mediterranean diet or the DASH diet, that stands for dietary approach to stop hypertension. They must provide specific examples of details for the clients to translate to the advice into meaningful actions. Okay, that's kind of what I was explaining before, right? It's not that please engage in a healthy eating pattern and they are not specific on what I need you to know. Just to give you heads up, doctors are studying 1 week or 1 semester of nutrition in the 5 to 6 years of their career. They don't have the preparation that the dietitian has, neither, or the nurses. We do study a full semester, and if you go into your family nurse practitioner, you are going to keep doing that. And if you want to get certified in functional medicine, that's all about nutrition. So we have the myplay.gov website. It's a great resource for menu samples, right? And here in this chapter, you are going to have a menu sample of the DASH diet. It's amazing. I was so happy to see that. Drug therapy in the event of the LDL cholesterol level is above the goal range or an individual has multiple risk factors. The AHA, and ACC guidelines for the management of food cholesterol provide an algorithm for determining the appropriate lipid lowering regimen. So there is an algorithm. In other words, for example, like in diabetes, no? The first medication to start is going to be metformin. In cardiovascular conditions, they are going to ask you first to change your lifestyle. Then second step is going to be to start in diuretics. That's the algorithm, right? Now, the third step is going to start diuretics plus one hypertension medication, or diuretics and statins, okay? So basically, they are treating everybody the same, under the same umbrella. And this is not individualized. We need to consider many factors, right? The patient socioeconomics, if the patient having comorbidities, if the patient is having a cultural habit. You cannot treat the patients. That's why it's so important that you learn nutrition, so everybody can adapt the best to their lifestyle. Okay. The guidelines recommend drug therapy for the following individuals: people with CVD or multiple risk factors who are less than 75 years old. Multiple risk factors: smoking, the obesity, the hereditary, People with CVD who are more than 75, and the following contingencies are met. The patient wants treatment. There is a potential for risk reduction, right? There are no significant risks for adverse event. So this is on a patient that is 75 and older. People with heart failure with reduced ejection fraction. So in these cases, the guidelines recommend drug therapy. Now, let's switch gears and let's talk about acute cardiovascular disease. When CVD progresses to the point of cutting off the blood supply to major coronary arteries, a critical vascular event like MI may occur. Now, we need to modify the diet during the initial acute phase of the attack to allow for healing. So, patient with acute cardiovascular disease, in the first part of the treatment, we need to modify the diet immediately. When the patient had cardiac arrest, the term infarction means tissue death from a lack of oxygen. Cardiac arrest, lack of oxygen. After infarction, the damaged heart muscle releases enzymes and proteins. These enzymes and proteins serve as cardiac markers and are one of the assessments used for diagnostics. So you have a cardiac arrest, blood work to assess those enzymes. Immediately after an MI, myocardial infarction, MI, or heart attack, the healthcare team may treat the client with, this is the MONA protocol, and this is NCLEX alert. You are going to be tested on this. the MONA protocol. So you have to administer your morphine to reduce the pain. Remember, the tissue is not getting oxygen. That's why people in a heart attack, they are touching their hearts with their left hand, right? They touch their chest, okay? Or maybe the pain on the arm. You have to provide supplemental oxygen, intravenous nitroglycerin, and aspirin. Okay, so nitroglycerin to lower the problem with the event, and aspirin is going to reduce the platelet aggregation. Okay, because you don't have the patient to have a clot. So it's the MONA protocol: morphine, oxygen, nitroglycerin, and aspirin. Okay, you need to be familiar with that for the NCLEX. Medical nutrition therapy for acute cardiovascular disease. The goal for patients with MI is as follows. Number 1, promote recovery and strength. Yes. Number 2, provide support in lowering LDL, because that bad cholesterol is the one causes the MI. Number 3, where's number 3? No more number 3. Okay. Initially, the diet may recommend diet modification specific to energy value and texture. After the initial acute phase, dietary modifications depend on the underlying cause. So if the patient is not having enough oxygen supply, right, the patient is going to have massive fatigue, and all the energy the patient has should be dedicated to for recovery, right? Instead of providing a lot of energy for the diet. So that's why the diet needs to change. It has to be very slight diet. Energy. Patients experience a lot of appetite because of pain, medication side effect, right? It's experience a loss of appetite because of this, or other complications. May benefit from a brief period of reduced energy intake to reduce the metabolic workload on the damaged heart. Okay, so we need to spread the meals into small feedings. Okay, and we need to push in such a way that we decrease the level of metabolic activity that the weakening heart must perform. And that's good to know. Nursing interventions, that's good to know. Texture. Early feedings may include foods that are relatively soft in texture or easy digest to avoid excess effort. So reduce energy intake in myocardial infarction. Okay, so a little bit of puree here and there, right? Long-term dietary modifications to reduce the risk for additional cardiovascular events and CVD progression. We are going to use the Mediterranean diet and the DASH diet, right? The Mediterranean diet, the basic components are plant-based food, nuts, whole grains, fish, and poultry. Notice that I did not mention red meat, okay? Limited red meat, moderate amount of dairy products and eggs, okay? Olive oil as a primary source of fat, the use of herbs and spices in place of salt, moderate red wine intake with meals, moderate, okay? Fresh fruit as dessert and minimal intake of processed food. Mediterranean lifestyles also include regular leisure time activity, physical activity, and structured exercise. If I were you, I will go to the internet and look for there is a pyramid that summarizes excellent the Mediterranean diet, and you can follow that. Okay. A recent review including data from 12.8 million people found that individuals following a Mediterranean food pattern have a lower risk of mortality, neurodegenerative disease. This is covering your Parkinson's, your Alzheimer's, your ALS, okay, cancer, diabetes, cognitive impairments, and CVD. Furthermore, adherence to a well-defined Mediterranean diet is associated with reduced inflammatory markers after an MI and improved endothelial function. So there you go. We can improve the tissue inside of the vessel that was damaged and then we can reduce the inflammatory markers. I use the Mediterranean diet for my capstone, for my DNP on patients that were cancer survivors, and in order to avoid recurrence, and it was really successful, really successful. So sodium, to reduce sodium content in food selection, we have to reduce sodium to prevent hypertension. And also we want to control the edema, right? A patient that is having problems with the heart is going to start collecting edema. So the restriction is 2,300 a day with the goal to 1,500 as we mentioned before, right? We have to use little or no salt in cooking. And then we have to avoid salty processed food. We have to read the nutrition fact levels, and we have to especially pay special attention to the sodium content per serving. And we are going to use the MNT guidelines for acute cardiovascular disease to the case study box, myocardial infarction, that's part of your homework. Sodium restricted diet recommendations, you have to go through these to get the knowledge of specific recommendations. For example, to avoid highly salted crackers, pretzels, potato chips, corn chips, salted nuts, and salted popcorn. Dr. Matalana, but you said that nuts are good. Yes, but get unsalted, okay? Limit processed food and convenience foods like cheese, peanut butter, rice, pasta, frozen drink, canned soups, okay? Limit spices and condiments such as bouillon cubes, your ketchup, your chili sauce, celery salt, okay. And then we're gonna make a break right now. We're gonna stop here, and then when we come back, we are going to talk about heart failure.